Okay, good morning, ladies and gentlemen. Now we have switched to the second CAS lab. Today's the prime operator is Dr. Ye. So please, Dr. Ye, introduce your team and your case information.
So thanks very much. This is a transmission from Nanjing First Hospital. Good morning. And today we will focus on a very interesting case with CTO lesion and the bifurcation lesion. My assistant, Dr. Chen Liang, and Dr.
Yun Fei
Deng will assist me to perform the case. And Dr. Chen Liang will introduce the characteristics of the patient, please.
Okay, good noon, ladies and gentlemen. It's my great honor here to share our case with you. As described by Dr. Yef, it's a very interesting case. The patient is a 41-year-old male and his risk factor include smoking and hypertension. The patient was admitted to hospital for chief pulmonary as unstable angina pectoris. And the patient's lab examination during the hospitalization shows it has a normal eject fraction, but had a little bit of change in his EKG, has SCT change. Okay, next. About 2 weeks ago, we has performed the right coronary artery, do the PCI for his right coronary artery, put 2 stents in his right coronary artery, and then about 1 week ago, we do the second time PCI for his left anterior descending. Today we focused on the lesion at the left circumflex, but it's very interesting because as we show in the picture, we can see here is the true bifurcation lesion in the proximal lesion of the circ, but still we can see there's a CTO lesion is distal circ. Fortunately, we Dr. Ye Fei successfully canalized the CTO lesion, and we found we have 2 bifurcation lesions. So okay, it's your turn now.
So could you calculate the risk stratification of this case before procedure? Show the next slide.
Next picture. Next.
So after performing successful PCI for RCA and the LAD, so today we will focus on the circumflex lesion. Combined with OM1 circumflex bifurcation lesion, 2 bifurcation lesion with a medulla 111, and this circumflex also also a bifurcation lesion. You cannot see it clearly just because there is a subtotal occlusion. Maybe total occlusion, we don't know. And now next piece, yes. Could you show us risk stratification?
Yeah, okay. We have calculated the syntax score before PCI for the patient has his syntax score was 16. It seems to be a lower risk.
Yes.
And his syntax score shows the PCI 4-year mortality was 4.2%, and his KBG was 1.3. Okay, next.
Next.
As we mentioned, today we are focused on the circ and the obtuse marginal bifurcation lesion. We determined to use the intracoronary image by IVUS to perform this PCI. Okay, thank you. That's all.
So we can see this is a very challenging case combined with a bifurcation lesion and subtotal occlusion, maybe a total occlusion. So Professor Zhang, could you give me some recommendation for this case?
Yeah, actually, it's a very challenging case. Although this patient is quite younger,
yes.
Considering the target is circumflex lesion, actually it's 2 lesions. One is a distal CTO lesions. Another is a very important challenge, difficult to access circumflex and OM. Before we treated the OM, I think we should successfully open the distal circumflex. So Dr. Ye, what's your strategy for this distal circumflex?
Yes, for me, it's a challenge. If we want to perform a PCI for distal circumflex CTO lesion, so the wire and the balloon will cross over the proximal lesion of the bifurcation lesion. We don't want to touch the proximal bifurcation lesion before we perform PCI for this lesion. So even though we want to use a wire, we want to use a microcatheter to support crossover the lesion. If the lesion was only simple, okay, open it and stand it. We don't want to pre-dilation the proximal bifurcation lesion. And so next view, we want to check every view of the circumflex distal part. So from previous one. Yes, even though we want to see it clearly of the distal part of the CTO lesion, we cannot get a very high quality of CTO lesion here. Then we just perform PCI with first wire. We want to use a hydrophilic wire with XD, with microcatheter exchange. So no, previous one. Yeah. So this is a AP quarter view.
Yeah, from the AP quarter view, there is the anterior flow, but it's not sure from the bridge lateral flow or the macro channel. So I think your choice is very, very right. Use a hydrophilic taped field wire.
Yes, maybe it's anti-grade flow. Maybe there is a macro channel between the proximal part and the distal part of the circumflex and the OM. So we use round wire with a workhorse wire to pass the proximal area bifurcation lesion and with a micro channel exchange. So previous one.
Is there any tip? Is there any the tip and the trick when you're shipping the wire tip of this field XT?
Yes, thank you very much. It's a very, very good and very important question. So with CTO lesion, we always use a very sharp length and a sharp tip and a very maybe 30 to 45 degree angle, just like a Gaia tip, Gaia wire tip. So next, after that, we use this is a XT, fit XT. After that, we can feel the XT. The tip of the wire was in a true lumen.
Yeah,
yes.
From the macro channel.
Here is a very important issue. Even though the wire was in the true lumen, we just push the wire. We cannot totally it very quickly. Just push. We can see it. The wire was in the true lumen, goes very smoothly. So next. So after wire in the distal part of the circumflex, we push the microcast and want to exchange a workhorse wire.
Yeah.
This is a workhorse wire into the distal OM, and we pull back the microcatheter with a 2O balloon pre-dilated with a very lower pressure. Also next. Also, that's very interesting. After we pre-dilate the lesion, we find another side branch there.
Yeah, this branch is not so small, and also the supply very distal. I think according to the length of the side branch, which means it's not so small side branch. Will you save this side branch with a wire?
Yes, and it's very important. Another question: we find another bifurcation lesion after we open the CTO lesion next. So after wiring with the workhorse wire, we use a 2O balloon to pre-dilate and we check the IVUS. So next. So this is this is a result after pre-dilate with side branch and we check the IVUS. Would you show us the IVUS?
Okay, let me show the IVUS imaging. The first run, we check IVUS from the distal OM to circumflex. And here we can see the distal IVUS guide wire is in true lumen, but the vessel is not normal. We can see eccentric plaque. The vessel diameter is about just 2.2 millimeter. Then go and pull back here. We can see hematoma in the proximal, the distal OM. Then go and pull back. We can see the side branch. Yeah, okay. Then at 12 o'clock, we can see circumflex will join OM. This is circumflex and the OM bifurcation. And the OM vessel is not very large. So we check another run IVUS from distal circumflex to left main. And here the distal vessel is normal. And the vessel diameter about 3.2. about 2.3 millimeter.
2.3. Yes.
Sorry. Then go and pull back, we can see eccentric plaque. And the plaque, we can see calcified plaque, but the calcification angle is not more than 180%, 80 degrees. So go and pull back, we can see the guide wire is a distal OM we are drawing circumflex. And here, this point flex. And here, this point, the area is just 1.8 millimeter square, and the plaque burden is just 66%. Then go and pull back, we can see the body circumflex. Here, we can see the vessel diameter about 3.3 millimeter. Then go and pull back. Here, this is a proximal circumflex. And then go and pull back, we can see the first OM we are drawing circumflex. Here, this is the circumflex and the OM1 bifurcation. And here, this point, the area is just 1.8 millimeter square, and the plaque burden is more than 80%. Then go and pull back, we can see calcified plaque, and the calcification angle is about 180 degrees. So go and pull back. As in proximal circumflex, we can see the vessel is normal, and the lumen diameter is more than 4.0 millimeter. We make sure the netness from the distal landing rule to proximal circumflex is about 58 millimeter, and the netness from the distal reference to circumflex and the OM1 bifurcation is about 48 millimeter. Okay, this is the baseline IVUS imaging.
So after can you successfully cannulate distal cell CTO and the predilation? So I will show actually distal cell and the OM2 is also true bifurcation, although it's a simple bifurcation according to the definition criteria. But from the IVUS imaging, maybe distal cell vessel tabulator is a little larger than the OM2. So Dr. Yeo, what's your strategy for this typical simple bifurcation lesions?
It's very difficult for me to treat this bifurcation lesion with a very small distal side branch and main branch. From the IVUS, we can see the distal circumflex was 2.3 reference diameter, but for OM2 only 2.2. So we want to stand in a larger branch. So give me next picture. So next picture, next. Oh, after that, we find the distal part of the circumflex was larger. We can see from the angle there is a landing zoom there. That's the reference diameter was 2.73. So we want to perform a 2.25 stand from the distal part to the middle part. So next, unfortunately, so next, we want to previous one. So after we want to push a 225/30 stand across of the lesion to the distal part, it's failed.
Oh, failed. Okay.
Failed. We cannot push the stand there.
Okay.
We don't want to predilate the middle proximal bifurcation lesion site. So how to do that? We recheck the IVUS. We found that there is a severe calcification just before the distal bifurcation stand. Could you show me the IVUS? We can see a very calcification there.
Yeah, I think there is circle calcification. Yeah, it's just before the second bifurcation. Yeah.
Go previous one. Previous.
Yeah.
Go back.
Yeah. Here.
No. Still go back. Just before.
Yeah.
No. Go back. Here.
Yeah.
So how to do next? We just use a 225 NC balloon to predilate with a very high pressure balloon just before the bifurcation, distal bifurcation lesion. Next, please.
So this is a typical scenario. IVUS can tell us why. What's the reason we cannot successfully advance the stand? Yeah.
Yes, this is a 225 NC balloon to high pressure predilate the lesion. So next, after that, stand cross over the lesion easily.
Yeah.
So next. After standing. So next. After standing. So we can see the OM2 osteo was compressed severely. So we won't perform a rewire. So next.
So you use the jet wire to protect the second OM.
Yes.
Yeah.
It's very, very important.
Yeah.
So previous one. Just because this is a 225 stand. So proximal part of the stand was under expansion compared with corresponding reference diameter. So after rewiring in the stand, we use a 2.0 balloon to push if the balloon crossover the proximal part of the stand easily. That means the wire was in the stand, was not under the stand structure. So next, this is okay. After wiring into the OM2 successfully, we push the 2.0 balloon across the lesion very easily. That means the wiring position was good. So next, we perform a kissing. So this is 2.0 balloon to pre-dilate with 30 atmosphere with 6 atmosphere, 30 seconds. 36,
longer time inflation. Yeah.
Yes, we want to standing just because the OM2 was too small. Okay. So next. So this is a 225 NC balloon performing kissing. So next. So this is a 225 post dilation proximally. So next. 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 So now. So even though we find that the OM flow was not very good, but it's acceptable. So we want to perform a kissing again, also standing OM2 again. Just leave it at that. We want to perform PCI for the proximal bifurcation lesion. So how to do?
Yeah, now let's go to today's target for this circumflex and OM. Very difficult access, very, very wide angle, and also severe narrowing at the bifurcation site. So I think for this scenario, I think first is we should successfully wire the OM1. So routinely, I think for this very wide angle, we will use dual lumen cassette for facilitate the wiring, and also the wire shape of the angle is very, very important. So Dr. Ye, can you introduce a procedure?
Yes, and it's a very challenging bifurcation for me with a very sharp angle between the main vessel and side range. The question is, no, stop. Previous one. Okay, and yes, the angulation was very, very sharp, over 90 degree, and the bifurcation side was very stenosis at the main vessel. That means the main vessel plaque burden was very high at the bifurcation core. And another question is how to select the first wire. First wire is very important for me I want to choose so the talkability was very good, and the tip of the wire was keep the shape was very, very stiffly and stably. And another question, another wire is hydrophilic wire is maybe the best choice, but we can not get a good support from the wire. And for me, first wire I want to choose runs to extra soft. If the wire failed, so another is a cyan blue or cyan blue may be better just because the tip of the wire was softer compared with cyan. Another, if still failed, so XT or XDR was the third choice. If still failed, and I will select a hard wire. But there is some information from the IVUS can tell me how to select the wire. So could Pentel tell me if you can find some information of the side branch of the OM from the main vessel IVUS? It's very, very difficult just because the bifurcation site was very stenosis. Maybe you cannot find the OM.
你能找到那一节吗？就是组织过分支口看分支口的那一节超声图像。
Yeah,
This
It-
point, this point, the
Could you
OM.
show the IVUS on the screen?
图像
Gradually from the distal to the POC, then go to the proximal.
Yes. Move the IVUS caster from the distal to the proximal.
Just at the
Yeah.
bifurcation site.
Yes,
here
yes,
us.
yes.
Yes. I will pull back.
Yes. Where's
Yeah.
the OM one?
6 o'clock.
Yeah.
6 o'clock. Okay. Just
The bifurcation angle is about
when you cannot
90.
find the angle.
90.
More than
Okay.
90. Yeah.
Okay.
19了
inverse
So,
angle.
Could you measure the length of the bifurcation diameter just at this part?
Yeah.
Only maybe less than 1 millimeter.
Yeah.
So we can see the members lesion characteristics was eccentric or without any calcified lesion. And the osteo OM was very stenosis, and the angulation was very sharp. So we want to use we also have a microcaster on the table, so we want to use this microcaster. If still failed, we use a double channel caster to support us to wire in the OM, just because this is a very challenging procedure.
So considering from the IVUS imaging, the POC plug burden, although very significant, very
Yeah.
heavy, but it's not so calcification.
Yes.
So your first wire choice is a workhorse wire run through
Yes.
with macro cassette support. So can you tell us what's the wire tip for this particular scenario?
Yes, it's very good question, and this is a very challenging shape with double channel. Give me
Give me
runs
wire.
runs wire,
The runs wire.
runs wire,
哪一个 runs loss？
a new one.
New one.
A new one. I will show you the how to shape the wire.
New one run through.
We also use
Double curve.
Double
Yeah,
curve.
double curve.
Just because the
封一下。
bifurcation side was very stenosis, so the length of the tip was very short. I show you how to shape with transducer. Yes.
Can the camera zoom the Dr. E's finger and tell us how to shape this run-through wire tip for this very angulated bifurcation
So
success?
the first length of the shape was only 1 millimeter. Nearly 90 degrees if it is possible.
Okay. And how about the second curve?
Another 1 millimeter.
Okay. More zoom. Zoom in the camera.
Could you zoom it?
Yeah. Zoom in.
Yeah. 看不太清楚。
再放大。
No. You talk the wire, Dr. Chen Liang, please.
旋转。
Yes. So with a double curve of the workhorse wire and a very short length. Yes. Okay. After that, we should use a double channel caster or microcaster to select, so to negotiate the osteos OM. So first, we use a microcaster just because the microcaster was on the table before we treat the distal CTO lesion.
Okay.
So next. This is a microcaster exchange procedure. Yes, you can see here, we zoom it with a double. We cannot push the wire, just a torque, just a run. Make sure, okay, you can find the wire tip in the OM easily.
Yeah, excellent technique.
So if this procedure failed, we can select another kind of wire with the same shape of the wire. If still failed, we can use a smaller balloon to pre-dilate the main vessel to make sure, just like the massage for the main vessel plaque. So we can make the space of the main vessel larger. So the wire in the circumflex may be a little easier. If still failed, what should you do next?
I think if still failed, I think next step is very important because the significant narrowing of the osteomal diagonal. So we will change the wire, maybe a stiff wire like a Gaia one, still with a double curve shape. Very cautious manipulated wire tip. Try to successful wire the side branch with a dual lumen cassette.
Yeah. So dual lumen cassette is very important just because it can make the space all in the true lumen. But only just like a fine cross corsair was not routinely used in this kind of bifurcation lesion. I think first recommendation is double channel cassette. After rewiring, we want to pre-dilate the OM and circumflex and recheck the IVUS to O balloon.
Okay, so you still use a small balloon to dilate the osteomal OM. Yeah.
Yes, another question is how to treat this kind of bifurcation lesion based on the angle.
Yeah, actually, according to the angel, it's although very significant, very difficult to access. It's a very short lesions.
Yeah.
So, and also you can see after you successfully wired the OM, actually the distal bifurcation angle is straightened and also smaller.
Yeah.
So at this scenario, I think I fully agree. I will dilate it with a small balloon, gentle dilated osteomal, the side branch, and check the IVUS. Then make a decision. No.
So this is a 2.0.
It's an older balloon. Oh, yes, successfully.
Yes.
Yeah.
Okay.
Pre-dilate. Okay.
Just because the angulation was still
there. Yeah.
Sharp and 2.0 balloon 6, 8.
Oh, still narrowing.
Yeah.
See.
10. Oh. Still there is risk.
Yeah.
10, 12.
Up. Yeah, we have achieved.
Go back to okay.
Fully open.
Okay, 6 again. We want to use a small, lower pressure to maintain it for a long time. 30 seconds. Just from the angel result based on the definition criteria, it's maybe a lot
complex bifurcation.
So we don't want to stand ON just because unfortunately if we make a dissection, maybe a severe hematoma, so bailout tactic is a two-stand technique.
Yeah.
For the original thinking about this bifurcation lesion, one-stand technique is suitable, I think.
So that's why you use a long-time inflation, the OM, avoid the dissection.
Yes.
Because your initial strategy for this case is the provisional standing.
Yes. After pre-dilate the side branch and the main vessel, we check the IVUS. Give me 2.0 balloon, please.
According to the definition, two trial is a randomized study proposed and organized by Professor Chen Shaoliang, and we report 1 year and 3 year clinical outcome for complex bifurcation lesions. Two-stand technique, especially decay crush, was superior to provisional standing in terms of TF at 1 year or 3 year follow-up. And the most important is in provisional standing, if we finally cross over the side branch group, it's the worst group compared with the two-stand technique, which means if we decided to treat provisional standing for the bifurcation lesions, we should avoid the standing the side branch.
Yes.
So for these scenarios, I think lesion prepare for the osteomal side branch is very important. Avoid significant dissection or hematoma.
Yes.
Otherwise, maybe just as Dr. Ye mentioned, maybe we will cross over our strategy to the two-stand technique.
Right. So after pre-dilate with a 2.0 balloon for side branch and main vessel, we give higher dose of nitro, and after that we check the IVUS for the OM. Okay. We want to make a dissection of the osteo OM. We don't want to stand the OM.
Yeah.
So how to protect the OM after vessel standing? It's another very important issue. IVUS can tell me how to protect. Angel also can tell us how to protect it, even though we use a wire protector, a balloon protector, or standing protector. So this is IVUS. Oh, go a little. Yes, go. Give me more.
Good.
So it's easier.
Yeah.
Check it. It's normal or okay?
Yeah.
Here is okay.
This is normal.
2.5. Yeah, at least.
Yeah.
I will pull back. Distal OM is normal. Vessel diameter about 2.5 millimeter.
It's a large side branch.
Yes.
Here we can see eccentric plaque,
Yes.
Yes.
calcified plaque. Here is normal. Proximal. Vessel diameter about 3.0.
Oh, 3.0.
Yeah.
Yeah. Okay. You can see the guide wire.
Oh, it's very
Mm.
interesting.
Nice, huh? Oh,
Okay.
very focused.
Just osteo.
Just
Just
osteo.
osteo.
Yeah, very.
Yeah, I will stop.
Yeah, just
Show
osteo.
the
Yes.
application. Yeah,
Yes, yes, yes.
Very short, very focused osteal obvious marginal lesions.
Yes, yes.
Plaque burden is not very large.
No, here still we should go more proximal. Yeah.
Yeah.
It's not so ostial OM margin.
Go little proximal. Pan down. A little
More
more
proximal.
proximal.
Anton, because it's nearly 90-degree angle.
Yes. Proximal. No. Go a little back. Yes, here.
A little.
No.
Proximal.
Two distal. Proximal.
Proximal.
Yes. A little proximal.
Little.
Little more.
More.
Still.
Yeah,
Yeah.
here.
Yeah.
And could you measure the MRA and plaque burden? So, just because just osteo.
This is a POC.
Yes, severe, a little fibrous case.
Actually, there is no significant dissection, I think.
Yes.
Dr. Ye.
98
Yes.
plaque burden.
Yeah. So what's your
78,
strategy?
78.
According to the definition criteria, the angel results show simple bifurcation, and
Yes.
the IVUS also show very focused short lesion just at the ostial margin
Yes.
after 2 balloon predilation.
Yes.
What's your strategy?
So one stand tactic to just use provisional.
Okay, I agree with, yeah.
So I recheck the IVUS for the vessel again to show the distal part of the stand and the proximal stand landing zoom to
Okay.
select the proximal stand size. So give me more. So okay, go to the
Okay.
back.
It's instant.
Yes.
Yeah,
In the
we should
proximal.
pull back
Yeah,
from
I
the
will pull
instant.
back.
Yes. This is a 225 stand.
The stand mean diameter is over 2.5.
2.5.
Yeah.
Vessel size is larger, yeah.
So I think maybe next we will use a larger balloon to post dilation at the first stand, instant, just before the bifurcation side.
Yeah.
This is a proximal stand age.
Yes.
The plaque burden very large.
Yes.
3.5 vessel at least for this
3.5.
reference, yeah.
Yeah.
So I think 3.5 stand was suitable for the proximal part. Here.
This is bifurcation.
Yes.
Circle and OM.
Yes.
Yeah.
This is proximal circumflex.
Mm-hmm.
The vessel diameter is over 4.0 millimeter.
For
Yeah.
okay.
very large.
Yes. So from the angle, we can see the proximal part of the circumflex. There is just like aneurysm there.
And this point is the proximal distal proximal landing zone.
Yeah.
Proximal landing zone, a little proximally may be better. You can see here is okay.
Over here.
Yeah. I think here is
here
okay.
is the landing zone. I think so. Yeah.
Yeah.
This point is better.
So still
You
can hear the osteo circumflex.
Yeah, this is the ostium.
Okay,
LED.
LED is coming. Okay, could you measure the length of the stand and select it for me? 3.5.
3.5. What's the length, Dr. Pan?
26.
26. Maybe we're very nearly to the ostial circumflex here.
Check the angle.
Oh, yeah. Test.
Yes, test.
Okay.
So just because the angulation between the OM and the circumflex was very sharp and wiring was so difficult.
Will you?
How to protect the
how to
OM?
protect?
Yes.
The very important technical
check the
issues.
Angle. So after wiring, we want to check the angulation between the OM and
smaller.
Yes, it's smaller.
Yeah, you will use jet wire or you will aggressively use a jet balloon?
Yes, it's a very challenging. For me, safely, I want to use jet balloon. It's safer.
Yeah.
So give me 3.5.
26.
26.
2
26.
Yeah.
From the
from the proximal circumflex to the distal
jet balloon.
Yeah.
多大的
？202
200
balloon.
200
How to select the jet balloon size, Dr. Ye?
Yes, and according to the I was finding the proximal pattern maybe 2.5 is a reference diameter. Sometimes I want to downsize jet balloon jet balloon size. This is to stand first. So for jet balloon technique, standing first, then balloon second.
Okay.
Okay. Stand.
Actually, so far we all know for DCB, its only indication is ISR lesion and maybe a small vessel lesions.
Yes.
But for this kind of simple bifurcation, especially for very short side branch lesions, so is this routine use DCB where superior to routine balloon dilation? We still don't know. And luckily, Professor Solians organized the DCB bifurcation and randomized studies. It's totally try to include more than 756 patient true bifurcation lesions one-to-one randomized to plain balloon dilation or plain balloon dilation plus DCB dilation for the ostial side branch after mammoth standing.
3.5 NC balloon. Just because the first stand was 2.5 size, so maybe the proximal part was on expansion, even though we cannot push the 3.5
NC balloon
across the first stand. So we use 3.5 NC balloon post dilation first. Make the bigger, so stand across to the distal stand easily.
Yeah, because from the IVUS imaging, the previous 2.25 stand is a rectal malabration.
Yes. Okay. Yes. 10, 12. Okay, done. Okay. 10, 12, 14. Okay, done. Okay. I don't know what's the reason. Okay. Okay, lower pressure. 6.
After 3.5 balloon
Okay, down.
pre-dilated POC zoom, the bifurcation site will do the angle check to see if we the pinched the OM.
Okay, Sydney.
That's good. A little.
We also find that the ostium OM one was a little pinched.
Yeah.
So we want to use a balloon to protect the side branch.
Side branch.
Yes.
It's a 7 French guiding cassette.
Yes.
Okay.
It's same French.
EBU
3.75. 3.75.
3.75 EBU.
Okay.
After that, we push the stand, I think, very easily. Okay.
Yeah.
Give me
good.
a 2.0 balloon.
New balloon.
Yes, 2.0 balloon to protect the OM1 ostium. Sometimes we use jet balloon technique with a large side branch or larger MMS. We use 7 French guiding caster, maybe suitable, maybe easily, compared with 6 French guiding caster. Okay.
Okay.
No, stop. No. Okay, test. See? No.
I think. What do you
No,
think?
I think a little longer is better.
Yeah, I stand
do you
is a
think?
little short. Yeah,
Yes.
maybe longer. 29.
This is
26.
Okay, give me another longer stand.
Yeah, or 30 is okay. Yeah.
Yes.
29 is okay, I think.
可以。
We should fully cover the proximal circumflex plug.
Yes.
Yeah.
Yes. Straight as a stand, please. Okay. Show me the previous one, Andrew.
The last angel.
Yes. I think it's a little shorter. Oh. Let's stop. Okay. That's because the wire will maybe crossover in the guiding caster. So we should push the stand first, then the balloon. It's maybe easier.
Yeah.
If we push the balloon first, no. Keep it. Balloon first, maybe stand cannot cross over easily. You might stop. Give me a little one. Give me a little one stand. Maybe it's the stand was damaged when we push the stand. After balloon was there, the stand may be damaged during the guiding caster. Maybe there is a very total route.
Okay.
Yeah. That's why for the dual lumen advantage over the single lumen cassette, when you revise the side branch, you can avoid the wire twist. Yeah.
Yes.
So that's why when we feel some resistance, yeah, we should avoid push the stand.
So we use another stand. So we push the stand first.
Yeah. Yeah,
Easier.
nice.
So when we push the balloon. So I think it's very important for the step-by-step for the jet balloon technique.
Yeah.
Stand first, balloon second.
Okay.
So balloon is there. So ready? No. Okay, send it.
Okay, send it.
Okay, now I think a little pull back is better. Yes,
yeah,
a
I
little
think
back
so.
is better.
Overlap enough, yeah.
Okay. Up.
Fail.
Okay, done.
Nice.
This is a 3529 stand. 30. Okay.
What's the next step for jet balloon technique?
Yes, I want to use the 3.5 NC balloon to push to the second stand and recheck the angle. If the flow was good, we will pull back the jet balloon
3.5块钱。
directly. Just we use ankle tactic with a 3.5 NC balloon. 3.5 NC balloon. When we pull back the jet balloon, maybe we find some resistance. Make sure there is a low resistance when we pulling back the jet balloon. If we find resistance, we find that the guiding castle was pushed into the coronary artery. It may be damaged, destroy the osteo left main. So we use the ankle technique to pull back the jet balloon. If we find deflection. Okay, just hold the wire, please. Hold the wire.
Okay.
It's very important step for the jet balloon.
Yes, when we pull back the jet balloon.
You should put a proper size balloon into a previous stand.
Yes. Yeah. Stop. You pull back the wire.
Yeah, you see. Yeah.
So sometimes we should.
Yeah, it's okay.
Make sure that the stand.
Nice.
Yes. We check the angle.
Take the angle.
Okay.
Nice.
If we find the osteo OM was compressed, we can perform the kissing in or out.
Okay.
Sometimes just because the stand. Okay. Inflection. 6. Yes. After that, we pull back the jet balloon. Okay. Stop. We can find the guiding castle was very stable without push into the left coronary artery. So there's the chance of the destroyed of the osteos left main was decreased. So we pull back the 3.5 balloon. So inflation first, 6 atmosphere. Yes, 6. Just leave it. Okay, keep it maintained for 30 atmosphere.
After the side balloon, jet balloon dilation, will you do the kissing or just
yes,
pull out the balloon and do the port?
Yes, it's very interesting. We don't know the rule kissing or not.
Yeah.
Just I think the main key point is keep the flow was better.
Okay.
And another is there is no dissection. So if we want to make the dissection, okay, pre-dilate, pull back, find the flow, okay, pot, and that's all.
Okay. So keep it open. Yeah.
Yes, keep it open.
This is a principle of the provisional standing.
Check the flow. Okay, flow is good
without dissection.
So we want to pull back the jet balloon.
Yeah.
Push the 3.5 balloon a little distally. Okay, inflection 6. That's enough. Pull back the jet balloon. Okay, stop.
Nice.
Stop.
So after you pull out the jet balloon, maybe the proximal stand segment will be deformation. So you will use a 3.5 to do the post dilation for the proximal stand segment.
Yes. So first is 3.5. Another is maybe a big one.
Yeah, for all, yeah.
So, okay, inflection.
4, 6.
Okay, done. After that, we check the flow. If flow is okay, we will pull back the wire. Okay.
Nice.
Okay. Inflection. Hunter, could you show me the proximal circumflex reference diameter?
For at
Okay,
least.
This
down,
point is the proximal. 3.8
3.8
lumen diameter. Yeah.
lumen diameter. Okay. Okay. Graph.
16.
So give me okay down. 40. Okay. Okay. No.
For NC balloon. Yeah.
Okay. Okay. So what's the key point of the final part of this kind of application? The question is to avoid to touch the criner. Just because if the final part cross over the bifurcation side, we will make the side ventral ostium.
Pressure a little damping. Yeah.
Yes. Yo. Sorry, maybe it's too deep. Yes,
Keep sitting. Yeah.
it's too deep.
The port is very important. Just as Dr. Yin mentioned, we should avoid the distal edge of the port balloon extending the carina. Otherwise, we will cause the carina shift again. Yeah. Especially for this very difficult access the wide angle bifurcation.
Now let the back test. Okay. I think port is very important. Okay, to use a special port balloon. Just because, okay, down. We can see the NC balloon shoulder was very longer, even though we make a precise position, but the balloon inflection, we can see the shoulder of the balloon extend, so longer, make the pot position was extended over the precise the okay.
Is there any?
Okay, done.
Still room for more proximal, yeah.
Sure. Wait a moment. No. Okay.
Okay. For balloon.
For balloon. Okay, done. After that, we check the angel and IVUS.
Nice.
Yes.
When pull out the NC balloon, because you use the NC balloon, the profile is big. The operator should be very cautious. Then the guiding tip intube too much cause the proximal stand damage. Yeah.
Yes. Sometimes we should pull out the guiding cast a little back when we pull.
Nice.
IVUS, please.
Before any round of IVUS check, we should give intracoronary injection of nitro and waiting enough time to take the nitrotic effect.
Okay. More.
Oh, this.
Okay.
Good.
Oh, IVUS, please. You check. Stop.
Pull out. There is the air bubble.
Yes,
the
I
flash,
think so.
the IVUS.
Flash, please. Flash.
Lumen can sit.
Flash. A little more.
Yeah, it's okay.
Okay. Okay. Oh, more. Give me more.
Nice.
Okay.
Okay, I will pull back.
So distal vessel was too small.
Yeah,
Less
the
than 2.0.
circumflex. That's the 2.
Yes.
It's a CTO lesions. Maybe
Yes.
3 months later, the vessel will enlarged due to the blood infusion. The wire is in distal saw or second margin?
Second, not second.
The
Third
distal saw,
has a
okay.
distal saw.
Okay. So this is actually extremely younger patient. So why triple vessel disease? So for this patient, what's the risk factor?
Hypertension and smoking.
Smoking,
Yeah, too much
hypertension.
smoking.
Great
He's a heavy smoker, I think.
Okay.
Quit smoking is very important.
Okay.
Small dissection.
Yes. I think I need a small dissection. No, okay.
Yeah, just at the stage, yeah.
Maybe we should put another small stent,
Yeah.
depending on if there is a landing zoom.
Okay.
No,
Okay.
diffuse lesion in the distal.
That means a distal lay. If there is low and suitable landing zoom, just
Hemi flow is good. I think.
yes, just pre-dilate for a long time. That's enough.
Yeah, long time inflation. Yeah,
Yeah,
it's a small vessel. Yeah.
Yes, then the expansion was very good.
Yeah.
Okay. Yeah.
It's a proximal circumflex.
First,
Yes.
stand mean diameter is more than 3.0.
Yes. Just below the first bifurcation lesion, I think. You cannot see the OM1. It's not coming.
Not find it.
Yes.
Yeah. One moment, maybe it's coming now.
Yes, I think so.
This is OM1.
Yes.
Yeah, we can see
yeah.
the
I think the Austrian is quite good.
good.
It's I think this bifurcation lesion, I mean the proximal circumflex bifurcation is very, very good evidence for depletion criteria. Even from the medulla classification 111, we should use a two-stent technique, but for the length of the side was shorter than 5 millimeter. So I think one stent is
Enough.
Yes, it's a very, very good result after my vessel standing. We don't need two stent to treat this kind of situation. Would you see any of the proximal part of the circumflex is good? It's a diffuse lesion.
It's also
Okay.
okay.
We can measure the distal part and the
The
proximal
distal
part.
stand age, we can find the medial dissection.
Yes, you can see it.
The
and
lens.
find the hematoma. And wait.
Give me 2 balloon. 2 balloon.
Here, hematoma.
220. 22. Yes. Could you show me the distal part, the normal part?
Is there any landing zoom of the distal, sir?
Yeah.
No.
The distal
too small.
Vessel very small.
Too small. Too small.
Yeah.
Maybe we can do the long time inflation and check angio again. Yeah.
But Timmy flow is okay.
Timmy flow. Could you show me the distal part standard age to the normal part of the distal circumflex? The length.
The lens.
Wait.
This is stand actually.
Maybe here.
No, more
15. Yes.
More than 15.
More than 15. Okay.
But the distal is not normal.
Yes. I use.
And the vessel is not more than 2.0.
That's enough. That's enough.
Yeah.
balloon is enough.
I just push. No.
So I think the stand.
No. Okay, enough.
6.
No. 4.
That's good.
Enough.
I think for the distal flow is quite important because the longer stem from the proximal to distal cell.
Yes.
Yeah, we should keep at least the tissue flow, and the radial stenosis less than I think 30%.
Yes. If there is a low hematoma, low dissection, there is low severe stenosis, we also can use a small drug-coated balloon to treat it. But flow is a most key point. That means most important issue.
Mm.
So could you measure the standard expansion in the distal and the proximal part and the middle part?
For the proximal landing zone is optimal. Less
Yes.
than 55%
Yes.
blood burden. 53, yeah.
So this is a proximal part standing landing zone.
Yeah.
Yeah.
Okay. The MRA was 5.40.
Okay.